Good evening, ladies and gentlemen. Welcome to a session with First Aid AMC course for question solvation of the sample questions. My name is Dr. Rabia. I'm one of the mentors associated with First Aid AMC course. I hope all of you are well. Let's just wait 5 more minutes and then we will start our class today. In the interim period, I will give a brief introduction to what our course is supposed to be like and how we can benefit you in passing your exam. Hello, everyone. Hello, Dr. Bushra, Dr. Sorin, Dr. Fava. How are you? So First Aid AMC course is for MCQ. We have a 5-month course in which we have different mentors in this course. Currently, there are 3 other mentors besides me. You already know about Dr. Arshad. He is the lead coordinator of the course, who will be taking majority of your classes and will be going through the theoretical side of every system very briefly and in a concise manner. Side by side to Dr. Ershan, myself, Dr. Shahana, and Dr. Mehvish will discuss the recent sample questions that are coming every month. So AMC conducts exam regarding MCQ. The AMC Center conducts exam every month, starting from January up till November, or early part of December sometimes. So we have new pool of questions every month that we try to get a hold of from our previous students and from other resources, and we'll try to discuss that in the classes with you. Also in this, during the sample question discussion classes, we will go through different tricks that will help you in solving the questions during exam in a timely manner. Also, we will discuss about if you don't know a particular topic, how you can reach a correct answer in the question as well. And we will also discuss about what sources we recommend for our students to follow, because AMC is very particular about some sources that you can use. And in Australian health system, the guidelines are followed to the T. So we will help you guys in accessing those resources as well. Yes, Dr. Bushra. These are the sample questions we get from the exam conducted each month. So we will take, there's almost 4 to 5 classes each week. And if you can join live with us, you can join through the link we post on the Facebook group that we create for our new badges. And if you can't join the live classes because of some commitments with job, with family, whatever your situation is, you can always find the recording updated in your portal system. In exam day, they will provide you with just one paper and pen, and you will be monitored during the entire exam by proctors. And they will let you calculate, like the questions that require mathematical calculation, they will let you calculate that. I'm sorry, Dr. Hera, the course is not free. There are trial classes that are free, and we try to put at least 3 to 4 at the start of every course so that you get an idea whether this course is worth investing your money or not. So this always gives you an idea about what this course is like and what will you be gaining at the end of this course as well. Alrighty. So I think we have enough amount of people joining us today. Welcome, everyone. So we are going to go through the recent sample question, and I'll be discussing about the tips and tricks about how to reach a correct answer. And usually AMC MCQ is based on your theoretical exams, and it's a junior doctor level exam. It's not a specialization exam. It's like an entrance exam. So your basics should be very, very good in order for you to pass the exam. Also, if you make a good base for AMC MCQ exam, that will help you to pass the clinical exam as well, because basics are always they always examine your basics in the clinical part of the AMC exam as well. Okay, so sources for the exam. We use a book is recommended for this. It's John Murtagh, latest edition. I believe there is edition 9 at the moment, but whatever the latest edition is, we will give you access to the soft copy of that edition in our course. Then there are particular websites which provide the guidelines which are followed. So for general practitioner type questions regarding population health, we use the RACGP guideline. For pediatric age group, there is RCH guideline and Queensland Children Health guideline. For obstetric and gynae, I recommend people to follow SA Health. They have very good flow charts. Health Direct is also good as well. For STI, there is STI Australia that has all the information you need about the population health. Then there are some particular topics like emergency medicine, some surgical topics that we ask you to read from Kaplan because they have organized that particular topic in a very good manner. And there are some hematology and orthopedic topics that we will discuss with you from MedBullets. So these are the rough estimation of the sources we will be using in the course to help you guys get a good base for passing the exam. So your updated guidelines is always recommended to be followed, but AMC MCQ sometimes don't follow them. So we will let you know which guidelines to follow. There was a particular issue about the colorectal screening guidelines. So whatever the guidelines in the red book of the screening tool is, always follow them. Okay. So in the exam, you will get a question sometimes with the picture on the side, and you'll have 4 to 5 options. And one of the options will be the best answers to select. Whenever I recommend my students when they are looking through the question is look at the age, where the patient is presenting, what the complaint is presenting, and what they have asked at the end of the line. So your end line is basically giving you a direction towards your answer. So this is a young adult male coming to a general practitioner. He's having irregular lesions on the foot. As you can see, there are lesions on the plantar surface of the foot. The person is a swimmer by occupation. Which of the following is the management of choice? Sometimes they will ask you the initial management, that the treatment you would start treating the disease with. Sometimes they will ask you about the best management, which means the curative treatment. In investigations as well, they will ask you initial investigation, and sometimes they use the word best investigation. So best investigation is diagnostic investigation. Gold standard is also the words they use sometimes as well. So gold standard, diagnostic, best investigation are all the same thing. So for plantar warts, these are warts, very common in people who have moist feet. So he's a swimmer. That means that his feet are always wet. So for plantar warts, the initial choice of management is we prescribe a cream with salicylic acid in it. Antifungal will not be recommended because wart is not caused by a fungal infection. Corticosteroids is not recommended for wart treatment. Either you can give something to stop the wart or you pluck out the wart. There are only two management choices for the wart. If the wart is cracked and you are scared that it might get infected, you might prescribe the patient with the antibiotic ointment as well, like mupirocin. But mupirocin, if the lesion is intact, there is no surface damage, then not recommended for the patient of plantar warts to be given mupirocin, okay? Mupirocin is best given to the patients who have impetigo and their lesions are not dried. That is the best treatment for impetigo, that you keep the lesions dry, you put dressings on it, and the other parts where you can't cover with the dressing, you put mupirocin on it. All right. And at the second page of the class, we will put a link like this that you can just copy and put it up in your Google link, or just click on it. And then it will take you to the page where we have taken this where we have taken this resource from. So it will generally give you the idea about the treatment. Okay, so in RACGP, usually they give articles like this, or sometimes they will be having a RACGP website guideline. So treating common warts, and we know that warts are caused by human papillomavirus. So very, very common, especially in patients who have particular areas where the skin is always wet, and it can be very easily transmitted just by touching. Okay, so diagnostic features of the cutaneous wart is that they are localized flat or dome-shaped papules with the well-demarcated edges. Histological findings, you don't need to remember, they don't ask you in your exams, and very common in the plantar surface, on the fingers as well, in between fingers sometimes. All right, so common wart, there are different types of it as well. So mycemia wart, common wart, butcher wart, plain warts, intermediate warts, they're caused by different types of the human papillomavirus. Sometimes they can ask you what type of virus is it. So it's important to just remember which kind of wart is associated with type of human papillomavirus. And all right. So fresh common warts, what can we treat the wart with? So initially, they are best treated with a salicylic acid gel, cream, or instant dry film preparation. So you have different strengths of it. If the patient is not responding to salicylic acid after 6 years, then you can ask the patient to use liquid nitrogen. So what does the liquid nitrogen do? It just freezes the wart and it falls off on its own. For facial lesions, very important for your exam, salicylic acid application is not recommended because it's very high strength and it will cause burns on the face instead of treating the warts. So the facial lesions always should be treated with the liquid nitrogen. This is also an MCQ of the exam. All right, and don't ask the patient to do the facial lesion liquid nitrogen application by themselves. Ask them to come to either the GP practice or go to a particular specialist like dermatology to get this done, because sometimes patient can put the liquid nitrogen on normal skin and cause burn there as well. So the lesions that are resolved with initial treatments have less chances of recurrence. If it's a recalcitrant wart, then you need to do, which is not responding to the liquid nitrogen. Then you can also use surgical treatment for that wart, or you can also use like a immunosuppression therapy as well, which is chemotherapy. All right. So this is surgical excision. It's the last resort. Firstly, we suggest salicylic acid, then liquid nitrogen cryotherapy. In some practices, they can use intralesional chemotherapy, but this is in cases where the warts are very recalcitrant. And fluorouracil as well. You need to discuss with patient about the pros and cons of the fluorouracil as well, as it has many side effects. So safest one are salicylic acid, liquid nitrogen, laser therapy, electrosurgery, and at the end, surgical excision. Okay. All right. Yes, we can do cauterization as well. Electrosurgery is electrocauterization. So electrocauterization comes after liquid nitrogen, and best is surgery. Yes. So best means that it is curative. But with this surgery, always remember if you recommended it for a facial wart, it can cause a lot of scarring. So it's best recommended that for facial warts, you use liquid nitrogen and laser therapy, not surgical excision or liquid or salicylic acid. Okay, let's move on to the next question. So this is how we go through the questions in the sample question solvation class. All right, next question. A young patient is unable to do right hand wrist extension, but he is able to do wrist flexion. And small hand movements are still there. Biceps and triceps reflexes are all normal, but brachioradialis reflex is absent. Most likely nerve involved is which of the following? Median nerve, radial nerve, anterior introitious nerve, or posterior introitious nerve? Okay, I'm getting answers between B, majority B, and an isolated B as well. Read the question again, guys. It's a young patient who is unable to do just one thing, which is wrist extension. He's able to do the small movements of the hand. He's able to do the wrist flexion, and triceps and bicep reflex is normal, but brachioradialis is off. So which nerve is affected? Okay. All right. So your answer is posterior introitious nerve. If the radial nerve is affected, then the triceps reflex should have gone as well. If the radial nerve is affected, then the small movements of the hand is also affected. But small movement of the hands are intact. Triceps reflex is normal, means that partial part of the radial nerve is damaged. That has caused wrist extension problem and brachioradialis problem. So a part of the radial nerve called posterior introitious is innervated to produce the wrist extension and brachioradialis reflex. So answer is D instead of B. Is it clear, guys? We are going back to anatomy. So let me just open up this nerve. Geeky medicos have very good. You have to study these innovation. This is important for your exam. Let me just open up quickly for you. Sorry, it's taking a bit of time. Okay, have a look at this one. So this is all of your brachial plexus nerves, musculocutaneous, axillary, radial, median, ulnar nerve. So radial divides into superficial and deep posterior atrocious branches. And the superficial posterior compartment of the arm, it supplies to triceps. And the posterior compartment of the forearm, the posterior atrocious deep nerve supply the wrist extensor, finger extensor, brachioradialis, and supinator. So when there is a problem to the posterior atrocious nerve, you will have a wrist drop with the loss of the brachioradialis reflex. If the injury is to the proximal humor or shaft of the humerus, then your tricep reflex, your wrist extension, your fingers extension, brachioradialis supinator, and brachioradialis reflex, all of it will be gone, and you will have a proper wrist drop without any wrist extension. Okay. But if there is a part which is below the arm, near the forearm, then you will just get loss of the cutaneous part of the posterior atrocious nerve with isolated wrist drop and loss of the brachioradialis. Your triceps will always be fine in that. Clear, guys? So this is the one that you can get it from Geeky Medicos. This is a very good diagram, very short summary of your all of the peripheral nerve injuries. It's very important. So always remember we have different dermatomes, right? So C5, C6, C7, C8, D1. C5, it supplies to the lateral part of the anterior cubital fossa. And it is C5 is involved in the flexion of the elbow. So biceps and brachialis, and it's involved in biceps reflex. C6, similar, you will have C6 will supply the thumb, and it will help in the wrist extension, biceps reflex, and supinator reflex. C7, middle finger, elbow extension, and triceps reflex. C8, phalanx, little finger, and it involved in the flexion. T1 supplies the medial side of the forearm, and it's involved in the abductor processes of the little finger. So you just need to remember about these things, okay? And very, very important for your exam. This one as well. Okay, let's move on to the next question. Now, sometimes they can ask you some ethical question or some professional questions as well, in which you don't need to follow anything, just follow common sense in there. And common sense in professionalism is that you need to practice safe medicine, in which you as a doctor is safe and the patient's care is in the safe hands as well. So by using all of those rules, try to solve this question. A person is going to join back company after injury rehabilitation. Committee board is going to review for worker compensation insurance claim. Employer asks for medical documents. First, the person agreed to release the document, but then he denies. What you would advise to the patient as a doctor? Tell the employer that patient has revoked the consent. Discuss with the patient what all document he want to submit with consent. Discuss with the patient if he understands the terms of worker insurance compensation claim. Give documents without telling him. Okay, so we are having mixed answers, C and B. let's do what I love to do when I don't know the answer is I do exclusion method. Give the documents without telling him is unethical. You should not breach the confidentiality of the patient. It is against the law. Tell the employer that patient has revoked the consent. By looking at option B and C, I think option A is not a good option because I want my patient to get compensation for the work injury. Discuss with patient what all documents he want to submit with consent. It is a good option. Discuss with patient if he understand the term of worker insurance compensation claim. Among option B and C, it's better to ask the patient why he is refusing the claim and what he understands by worker compensation insurance. And then you will be able to help the patient decide which documentation he can provide the employer that can help him to get the compensation claim. So among all of this, instead of getting B, I would select C because it will help me understand better what the patient is worried about, and I will be able to help the patient based on that. So answer would be C. Once you know what the patient is worried about, then you can discuss with patient what he wants to submit. Are you guys getting what I'm trying to say here? So you need to find out here why the patient has revoked the consent or asked the medical documents not to be released. Once you understand what the patient understands about the worker compensation, then you can guide the patient to the best of your ability about what documentation will help him get compensation from the work insurance. All right. Next question. You will get a lot of these questions. They love to give ethical questions relating to professionalism, related to, there are some questions in which there are 4 things that APRA needs to be informed about so that they can cancel the license of a practicing medical officer. So you should be aware about those big red flags. Okay. Post-cataract surgery, a patient is having a red eye. So they have given an image. Let me just put up an image for you. Sorry, I should have put an image up there. All right, this is your image. So post-cataract surgery, patient is having a red eye. Vision is not a problem, 6/6. Vitals are normal. Next morning, there is pain in the eye with the red fluid in the anterior chamber. What is your diagnosis? Hyphema, hypopyon, subconjunctival hemorrhage, glaucoma. Very good. So this is a hyphema. Hyphema means there is blood in the anterior chamber. You can easily diagnose this patient clinically. So if you see the iris, this is the iris, and this air fluid level is there, and this is all blood in the anterior chamber. This is called hyphema. If this was in yellow color, this would be called hypopyon, which is pus in the anterior chamber. And it is a sequel of anterior uveitis, the hypopyon. Hyphema happens because of the surgical problems in the patient or patient who are having very high pressure inside the eyes. They can sometimes have hyphema as well. Subconjunctival hemorrhage is different. Let me show you guys what it looks like. Subconjunctival hemorrhage will look like this. So this is subconjunctival hemorrhage. If within the conjunctiva, if you have a hemorrhage, then this is called subconjunctival hemorrhage. And glaucoma. So glaucoma will have very particular appearance in which the eye will be very huge because of the high pressure of the eye, and cornea will be hazy and your pupil will be unreactive to light. Show you guys what it looks like. So this is the picture of glaucomal eye. See, the cornea is very hazy and pupil is unreactive to light, and it's very huge and red eye. Yes, very good, Dr. Shabir. There is ciliary congestion in the conjunctiva in glaucoma. There is ciliary injection here as well, but you can clearly see the cornea is not hazy. It's having a hemorrhage in the anterior chamber. Okay. Have a look at this. These are the differentials of the red eye, painful red eye. So if it's an elderly population or mid 50s to 60s, then a patient is coming to you with painful red eye, one eye, and complaining of vision problems, flashes and floaters around the eye, then always think about glaucoma first. So it is acute rise in the intraocular pressure because of the blockage of the aqueous hemorrhage. Patient will have injection, corneal haziness, unreactive pupil. Okay. Um, so what do we do with these patients? Because they're having, this is an emergency. Patient will be having headache, patient will have nausea and vomiting. So we need to decrease the pressure of the eye. The first thing that we do is give acetazolamide. The second line is we give beta blockers, topical. Third line is we can also give some prostaglandins that can help to decrease the pressure within the eye as well. And these patients, if they're having a surgical blockage of the drainage of the aqueous humor, then they require urgent ophthalmological review and they require surgery to release the pressure as well. Iritis, we all know, inflammation of the iris can be caused by the viral infection, very commonly caused by viral infection, to be honest, but can be caused by some drugs and associated with some autoimmune disease as well. Keratitis is the corneal inflammation, very commonly associated with the foreign body or infection within the eye, could be bacterial, viral, fungal, or parasitic infection. Patient will have pain in the eye, photophobia, lacrimation. So you need to treat the cause in there. Scleritis is the inflammation of the sclera, very commonly associated with autoimmune disorders like um, inflammatory bowel disease, ankylosing spondylitis. All of these are associated with scleritis, and it's very, very painful, like very severe pain in this patient. So you need to treat it urgently with painkillers. And I think in autoimmune disease, you give steroids to the patient. Hyperacute bacterial conjunctivitis, very common in children, especially in newborns, if they're having bilateral gunk in their eye, sticking of the eye, conjunctival injection, think about chlamydia or Neisseria infection of the eye, and you need to treat it with the IV antibiotics. Corneal abrasion, very common as well. Foreign body can cause disruption in the cornea that can cause pain. So you need to wash the eye and do a fluorescein staining to see where the rupture is. And these patients need to be sent to the ophthalmological review whether this requires a repair or not. Yes, this is the dendritic ulcer, which is seen in the HSV infection of the eye, which is viral keratitis, very common as well. You can also study hyphema from this as well, but it just gives you an idea about what are the side effects of the cataract surgery are. So you can get immediately hyphemia, but after some days, you can also get anterior uveitis leading to life-threatening infection that can cause you to lose sight in the eye, which is endophthalmitis. All right. Any question, guys? Can you please say the third line treatment for glaucoma? Let me just bring out the guidelines for you. Okay. Have a look at this one. This is the Monash University guideline for glaucoma treatment. Depends upon the severity. So they have discussed about mild, moderate, severe. So you need to reduce the intraocular pressure. Initially, topical pharmacotherapy is the mainstay treatment. So first line, we do acetazolamide. Then second line, we do beta blockers or prostaglandin. And third line, let me have a look. So you have prostaglandins, you have beta blockers. Yes, alpha-2 agonists, sorry. I forgot about those. Carbonic acid anhydrase inhibitors, which is acetazolamide, you can give patient orally or IV. It can be it's very easy to give those. It decreases the eye pressure, but simultaneously you have to give the patient beta blocker as a second line. Very, 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 very important. Prostaglandins can also be given as a second or first line as well. Alpha-2 agonist, I think, is the third line. What else? Cholinergics are also third line as well. Emergency management of glaucoma is different from OPD. So in OPD, you usually manage the chronic glaucoma, but in emergency, you manage the acute glaucoma that can cause you to lose your eyesight.
Guys, reading time.
Sorry, guys. I would request you to mute yourself. If you have any questions, just ask in the chat box, please. Thank you. Okay. Next one. Any question, guys? Glaucoma is very important for your exam. Just a heads up. Very, very important for your exam. Acute glaucoma, not chronic one. Acute glaucoma is important for your exam. Okay. In John Murtagh, it's IV acetazolamide. Beta blocker is the first line agent, topical. All right, next question. An old lady has sudden onset of back pain after opening window. She has a background of diabetes, high blood pressure, osteoporosis. Imaging, which is most of the time is a CT scan, shows she has a L4 collapsed fracture, not displaced. Her ESR is also raised, and she has pain in the morning, even before injury, which was relieved by rest and paracetamol. What is the cause of the back pain now? Osteoporosis, ankylosing spondylitis, diabetes, or nerve compression? Very good. So it's very clear that now, because she has a collapsed fracture, there might be some nerve compression that is contributing to her back pain at the moment. Chronic back pain that she has been having with pain in the morning that gets better with rest and paracetamol and ESR is raised. What are you thinking about? Is it osteoporosis or rheumatoid arthritis? Ankylosing, Dr. Zaini, doesn't happen in old ladies. Ankylosing is a disease of the young person, especially males. So if you're thinking about pain in the morning that gets better with rest and paracetamol with a raised ESR, think about rheumatoid arthritis. Osteoarthritis starts with pain in the morning that gets worse during the day. So it doesn't get better with the day, it gets worse during the day. And in osteoarthritis, your ESR is normal. So our answer here is nerve compression. Very good. Sometimes they will use big words, throw in a lot of comorbidities and ask a very simple thing in the end. So don't Don't lose sight of what they are asking in your question, okay? That's the trick of the exam. They will throw in big words and try to lose the focus of the question. So don't lose the focus of the question. Yes, here the key word is now, not the chronic back pain. This is the key word. Okay. In elderly population, there are some things that you should always be aware of, especially if they're coming with the back pain. So red flags for the low back pain, they include certain serious pathologies. So always think about fracture, whether they had a minor trauma or major trauma, or is the patient osteoporotic or not. Number two is that you need to rule out whether patient is less than 20 or more than 50 years of age. So that's why less than 20 ankylosing spondylitis, more than 50, most of the time osteoporosis leading to fractures. History of cancer is very important. So in cancer, you will also ask symptoms like night sweats, weight loss, lumps and bumps on the body, repetitive infections in the body, or ask the patient whether they are IV drug user or not, because septic arthritis or osteomyelitis of the back can also happen, whether patient is having immunosuppression, and whether patient is having pain worse at night. These are the constitutional symptoms of cancer. Also, always ask about any neurological symptoms. So if patient is having bladder or bowel incontinence, sedal anesthesia, these are the signs and symptoms of cauda equina, which is a medical emergency. And it can cause permanent paralysis if not treated on time. So with the back pain, always look for red flags. Okay. L4 collapse can cause compression of the L5 nerve, which is coming down from there. Yes, it is the collapse is causing nerve compression, which is causing pain in her back at the moment. Her chronic pain was caused by either osteoarthritis or rheumatoid arthritis. But right now, the acute pain she had when she opened the window is because she had a L4 collapse fracture, underlying osteoporosis leading to nerve compression. No worries, Dr. Bushra. All right. Next question. This is one of the most repeated question I have seen. You should know about what kind of tumors are common in children or pediatric age group and which symptoms they present with. All of the brain tumors in children presents with headache, early morning vomiting, or neurological symptoms, either altered level of consciousness, behavior, personality problems, speech or swallowing problems, or neurologies in the limbs. So always look for signs and symptoms like that. Some tumors present differently. For example, like this tumor, a 6-year-old female oh, you can't see. Sorry, I forgot to change the screen. Are you able to see the screen now, guys? Sorry about that. Okay, so a 6-year-old female is coming with pubic and axillary hair, breast buds. So very, very young age group, but having secondary sexual characters. She's brought to the GP practice, also complaining of headache and vomiting. So this gives you a source that it may be something wrong with the brain or the hormonal system that is causing her symptoms. What is the following is the most likely cause of her symptoms? Medulloblastoma, ependymoma, sorry, it's a tongue twister, craniopharyngioma, glioblastoma, or pineloma. Okay. Medulloblastoma, agreed, is the most common tumor in the pediatric age group, but she is having secondary sexual characters. So medulloblastoma doesn't cause secondary sexual characters. Ependyoma, craniopharyngioma, less likely. Glioblastoma, less likely. Pineloma causes precocious puberty because it's the tumor of the pineal gland, pineal body, sorry. So answer here is E. Let me explain this to you. I'll open this up. Okay. Have a look over here. What is pineloma? It's the tumor of the pineal gland in the brain. It's a tiny organ near the center of the brain that secretes certain hormones, including melatonin, which is involved in the regulation of the symptoms. There are different stages. Don't worry about the stages. It can be benign, it can be malignant. Symptoms of pineloma. So common symptoms of the brain tumor: headache, nausea, vomiting, vision problems, feeling tired, irritability, trouble with the eye movement, difficulty walking, tremors. So these are all the tumors of any brain. These are all the symptoms of any brain tumors. Particularly with the pineal gland, you will have precocious puberty. This is when girls begin puberty before the age of 8 and boys before the age of 9. So symptoms of secondary sexual characteristic in people less than 8 or 9 years of age with associated brain tumor symptoms, always think about the pineloma. So breast growth in girls, testes growth in boys, rapid increase in height, changes in body size and shape, pubic or underarm hair, changes in body odor. In addition, sometimes girls will also come with their first menstrual cycle, or boys will come with the facial hair or changes in the voice as well. So depending upon the size, they are treated accordingly. How will you diagnose it? In children, very small children, we don't recommend doing a CT scan unless very much required, but MRI is the gold standard for it. Sometimes biopsy is done, sometimes not, but lumbar puncture is always done to see what kind of tumor cells they're having in the CSF. Blood test will also be done to see whether other organs are affected or not. So depending upon whether it's benign or malignant location, tumors are surgically excised or treated with chemotherapy or radiation. Okay. So prognosis is 5-year survival is 69.5%, good survival rate in there. But if it's a big tumor encroaching within the brain and causing a midline shift, then chances decrease accordingly. Clear, guys? Oh. Any questions? All right. One of the most favorite topic of AMC exam, vertigo. Patient is coming with vertigo symptoms, but no vomiting. So what are the vertigo symptoms? Can anyone tell me what are the 4 symptoms which we are looking for when a patient is presenting with vertiginous symptoms? So number 1, room spinning, right? Number 2, nausea, vomiting. Number 3, disequilibrium. Number 4, we always look for vertiginous symptoms. We always look for any neurology. Tinnitus is a different thing. So there are causes for peripheral vertiginous symptoms. There are causes for central vertiginous symptoms. So peripheral vertiginous symptoms are very benign causes, right? It's something to do with your ear most of the time. So infection within the ear, some crystals within the ear, or some problems with the flow of the fluid within the ear that will cause peripheral vertiginous symptoms. But in central vertiginous symptoms, we are very concerned about whether patient is having posterior circulation infarction, because that sorry, I'm not doing anything. I'm just talking to you guys. I'm not showing you anything except the question that's on the screen. But I will show you guys what I'm talking about in a minute after we solve this question. So vertiginous symptoms, always think about the peripheral causes, central causes. So we always try to rule out posterior circulation infarction, which is very difficult to do so. So vestibular assessment is very, very necessary, which is the hint test. So hint test includes 3 tests. HI is head impulse test. N is checking the nystagmus. And TS is test of skew. These are all the tests we use to detect any central or causes of the vertigo. For peripheral vertiginous symptoms, we can do Hall-Pike maneuver. So a patient is coming with vertiginous symptoms, no history of vomiting, no hearing loss, head impulse, nystagmus, test of skew, test is positive. That rules out acute central causes of vertigo. What is the management? You will give antiemetics like ondansetron or metoclopramide. Will you give beta-histine or some antihistaminic agent? Very good. So we will give patient beta-histine, prochlorperazine that can help with the dizziness or a room spinning sensation. Very good. Patient is not vomiting. So we don't need to give antiemetics to the patient, not vomiting at the moment. So no benefit of giving that. Okay, so let's go to RACGP. Okay. Are you guys able to see the screen? No, here the diagnosis is peripheral vertigo. Approach to vertigo in general practice. Are you guys able to see that? There's one person, let me know, please, in the chat box. Oh, thank you, Dr. SM. All right. So very, and I can't emphasize enough how common this presentation is in the hospital in your GP practice. So the dizziness or the sensation of room spinning, which is vertigo, it can be central, it can be peripheral. As I talked about, it can be caused by cerebral problems with the brainstem, or it can be caused by problems in the inner ear. So careful history and physical examination will help you rule out whether it's benign paroxysmal positional vertigo, vestibular neuronitis, Meniere's disease, or it's a posterior circulation infarction. So patient will come to you and will say dizziness. Dizziness is completely different from vertigo. You need to ask them, what do you mean by dizziness? Whether there's the sensation of the head spinning or whether you think the room is spinning. If they say head is spinning, that is dizziness, that is lightheadedness associated with low blood pressure, anemia, stuff like that. But if they say that the room is spinning, oh, patient is having a vertiginous symptom, spinning sensation. Then talk about whether patient is having disequilibrium or not, which is feeling of imbalance associated with it. Vertiginous symptoms with disequilibrium present in both peripheral and central causes. Okay. Lightheadedness is the sensation of fainting. Pre-syncope, sensation of feeling faint. Most of the time, it's associated with central causes, but can be present in the peripheral causes. So your physical examination will try to rule them out. Okay. You have to ask them about whether they have weakness, speech swallowing difficulty, vision changes, headache, yada, yada, yada. And you will ask them about any recent infection or not, because you want to rule out vestibular neuritis, neuritis. And you will ask about any ringing in your ears or stuff like that. Very easy to rule out in the history. But if the patient is hypertensive, diabetes, myocardial infarction history, be very, very careful that you need to clarify that we are not missing the central cause. Physical examination, you guys must know this on fingertips for your clinical exam and your MCQ exam. So ENT examination, in ear examination, you need to see whether the patient is having any problems with the hearing, zoster infection there or not, or whether the patient's vertiginous symptoms are caused by the Valsalva maneuver. Hearing assessment, not usually done in emergency. Just ask grossly whether the hearing is intact or whether you're having reduced hearing in either of the ears. Neurological examination is very, very important. So you do the cerebellar signs, that is gait. Then you do the Romberg test, heel toe test, or finger nose test, dysdiadochokinesia, and try to rule out the central causes. Eye examination, you need to check for nystagmus. So if the nystagmus is present in the horizontal direction, it's most commonly associated with the peripheral cause of the vertigo. But if there is a vertical nystagmus, this is only seen in the central cause. Okay. Then you need to do a cardiovascular examination, of course, because we want to rule out stroke symptoms. Now, very important, you need to do a Hall-Pike maneuver. You need to do orthostatic blood pressure testing and head impulse test, test of skew as well. So Hall-Pike maneuver is diagnostic for benign paroxysmal peripheral vertiginous symptoms. What you do is that you set the patient at the head of the bed and you turn the patient head to one side, whatever side you want to examine, left and right, doesn't matter. Then you ask the patient to keep their eyes open and focus on a particular point while their head is turned one way. And then you quickly put their head to the bed in the supine position and hyperextend their neck. If you see their eye moving in the horizontal nystagmus direction, this is a positive test for benign paroxysmal positional vertigo. Orthostatic blood pressure testing can also let you know whether patient's vertiginous symptoms is caused by a drop in the blood pressure. Head impulse test, very, very important again. So similar to Hall-Pike maneuver, where you ask the patient to look at the examiner's nose and then examiner turns the patient head quickly. If you observe that their eyes are moving in a horizontal nystagmus and failing to fix on the examiner's nose, then this is a positive test for the peripheral cause. Let me show you guys a video of it. You will be better able to understand. So this is how Hall-Pike is done. Okay. you have to let the patient know about what type of test you're going to be doing. So ask the patient to sit, and then you're going to be moving the patient's head completely lateral to 45 degrees and then lower them down and then hyperextend their neck. If you observe nystagmus in the horizontal direction, then this is positive and should be repeated in both sides because sometimes it will help to resolve the vertiginous symptoms of the patient. Similarly, then you do Epley maneuver. How to do Epley maneuver, which is a curative test. So you turn the patient head and maintain, and then you turn the other way. Ask them to fixate. See, you're moving. This is how you manipulate the fluid inside the ear. This is how you maintain the fluid so that it stops causing the patient vertiginous symptom. This is Epley maneuver. Lie them down, rotate their head, put the patient in the supine position. Again, rotate the head. Clear, guys? Okay. So if you're thinking about peripheral cause, then upper respiratory tract infection symptoms can cause vertiginous symptom. Yes, Epley maneuver is done in hospital, is done by the physiotherapist. So differentials are BPPV, vestibular neuronitis, labyrinthitis, Meniere's disease, and central causes is the infarction. If you're always concerned that the patient is elderly, having head impulse, nystagmus, test of skew. Let me just put that up for you guys here. This is the hint test. Is to rule out central vertiginous symptoms. So if you do a head impulse test and there is a corrective saccade, which is the movement of your eye towards the center with the rotation of the head, it's abnormal head impulse test, which is present in the peripheral vertiginous symptoms. No corrective saccade is not present in the central vertiginous symptoms. Nystagmus, if it is horizontal and unidirectional, meaning in one direction, then you have a peripheral cause. In central vertiginous symptoms, it's vertical nystagmus. Test of skew is when you cover one eye and then you fix the other eye and move the eye around. If there is a deviation or again a nystagmus of the eye, then it is positive. If there is no nystagmus, test of skew was you cover one eye, ask the patient to look at one direction, and if you don't observe any vertical nystagmus, then this is positive for peripheral vertiginous symptoms. If there is vertical nystagmus within a single eye, then this is skew deviation. Let me open this up for you and put it over here as well. Sorry. Okay. This will always give you an idea about things. Okay. Clear, guys? All right. Let's do one more question and then we can go on a 10-minute break, okay? A young female, disoriented in the market, was taken to emergency department. Blood tests show that her sodium level is 112. Rest of the investigation is normal. What would you do for management? normal saline for 6 hours, 3% normal saline, which is hypertonic solution, or give dextrose with normal saline. Very easy question. Patient is having what? Can anyone tell me? Hyponatremia. This is not SIAD. So syndrome of inappropriate ADA secretion needs urine osmolality, plasma osmolality, and serum sodium for diagnosis. This is hyponatremia that is causing CNS symptoms. So this is an indication for the patient to be given hypertonic sodium, 3% normal saline, 100 mils over 30 minutes. So, and this always should be done in either a HDU setting or ICU setting, okay? So look at this chart. If the patient is having hyponatremia, seizures associated, or altered level of consciousness, then this is a medical emergency. Call for help. Give 3 millimils of per kg IV, 3% sodium chloride over 30 minutes, which is usually 100 mils. It's not more than that. And recheck the sodium after 30 minutes. So 10 minutes, you will let the sodium sit in the body and do a VBG again. Recheck the sodium. If the patient is having concomitantly seizure, then also you can increase by sodium up to 5 millimole per liter. Or if the sodium level has reached only 125, then you can correct the sodium by no more than 2 millimole per liter, so that you don't exceed 10 millimole per liter in the next 24 or first 24 hours. Once your correction is done, reduce the amount of sodium that you have to give to 8 millimole in 24 hours, and then you check the plasma sodium every 4 hours. Easy way to remember is that if the patient is having hyponatremia, altered level of consciousness / seizures, instantly you give 3 mils per kg of 3% hypertonic solution over 20 minutes. Check the sodium again. If the sodium is more than 125 or patient is having seizure, then you need to give increase the sodium by 5 millimole per liter, which is 2 millimole less than an hour, and 10 millimole in 24 hours. If it is corrected, then you decrease it to 8 millimole per 24 hours in the next 24 hours and measure the plasma sodium. If the patient is not having hyponatremia, but not altered level of consciousness or seizures, then you assess a hydration status, whether 3% sodium is indicated or not. Most of the time, patients who are having hyponatremia will also be dehydrated. So if they're not having any CNS symptoms, you can just rehydrate them with isotonic solution. All right. If the patient is dehydrated less than 130, you can give them IV. If it is 130 to 134, oral rehydration solution. If the patient is euvolemic or in fluid overload, then you can fluid restrict them and you can give them some isotonic solution once you have maintained their fluid balance. If the patient is not improving, then you can give them small amount of sodium, which is 8 millimole per 24-hour maintenance for the hyponatremia with altered level. If the patient is not having improvement with that, then you can discuss with the clinician whether this patient will be good candidate for 10 millimole of sodium in 24 hours or for hypertonic instant 30 minutes infusion. Clear, guys? I think it was too much information, but very important for your exam. Just a heads up. Okay. All right. Let's take a 10 minutes break and we'll come back and finish this. 10 minutes break, please.
අනේ ඒකනේ ප්‍රශ්නේ තිබ්බේ. කියන්නේ මට කවදාකවත් ලයිව් ක්ලාස් එකට මේ ඉන්න හම්බුන්නේ නැහැ. මම හැමදාම රෙකෝඩඩ් ඒවා තමයි බැලුවා. අන්තිමට ඒක හැමම ඒ පුරුද්ද ගිලිහිලා ගියා. ඒක දෙන්නේ. ඈ අනේ හොයන්නකෝ අනේ. ආයෙත් එළිය අර මේ කරලා බෑ. එළිය දොර ඇරලා බෑ. අපි හෙට උදේට අහන්න ඕනේ. රෑ 12ට කරනවනේ එයාගේ
All right, class, welcome back. Let's restart our questions again. I hope you had a good break. All right. Are you guys able to see the screen? All right. Question is, a girl with Turner syndrome is concerned about her height, that her height is less than her peers. What is the initial investigation would you do for her regarding her short stature? Echocardiography, X-ray, thyroid. Very easy question. So what do we do with the X-ray? What do we see with the X-ray? What is the X-ray going to tell us? Yes, we see the bone age, right? To see whether the patient is having constitutional delay or whether the patient is short-statured or having a stunted growth, basically. Have a look at this flow chart here. So if the patient is coming to you with short height or absent pubertal development, either of the things, at 13 years in female or 14 years in male, what do we do as an initial investigation? We will do a bone age evaluation by X-rays. And if she is concerned about the pubertal symptoms, then we will also do LH and FSH levels. If the bone age is less and patient is having low hormones, then most of the time you will have gonadotrophin problem or constitutional delay. Sorry, if bone age is less and inappropriately low, then most of the time it's the gonadotrophin problem. But if you have a high level of hormones, irrespective of bone age, then this is primary hypogonadism. Then you need to do karyotyping in the female and males to see whether they have any chromosomal problems like Turner syndrome, Klinefelter syndrome, DSD forms, or for primary ovarian insufficiency syndrome. If bone age is more but hormones are low, then partial pubertal development is likely. It could be central hypogonadism. It could be functional or organic cause. So you do a brain MRI and you see whether the patient is exercising, starving herself, things like that. Stress is there or not. Okay, so this is how we evaluate constitutional delay in the growth of the patient and pubertal development as well. Both are basically the same thing. We start with the same thing. Okay. Next one, baby and sister has itchy rash. Very easy. Treatment is permethrin. Very good. So we are thinking about scabies here. If family members are presenting with rash, itchiness, always think about scabies. Okay. Very particularly, scabies will have tracts and burrows in your palmar areas, in the flexor areas. Let me show you guys what scabies look like. Scabies, skin lesion, and they will sometimes have superimposed bacterial infection as well. How scabies looks like. There are track marks, and then you have superimposed infection as well. Quite itchy. and it's caused by a parasite. Okay. Have a look over here for scabies treatment. What do we do? Permethrin, 5%, the topical antiparasitic cream that you apply to the whole body. So you do it for at least 1 week after the initial treatment. Children, you apply the cream to the whole body, but not face and neck. Infants, you apply to the whole body, including neck, face, ears, and scalp. Amounts is different. If the patient is having other problems to control the itch, you can give calamine lotion, antihistamines as well. Most of the time, patients will have secondary bacterial infection as well. So you can give mupirocin 2% ointment as well. Every clothing in the house should be washed in hot water and dried in sun. Or where this is not possible, they should be ironed or stored in a sealed plastic bag for 72 hours to kill the parasite. Now, there are different recalcitrant form of scabies as well. This is how it looks like. Down. Okay, so in very, very young people, 2 months of age, instead of giving permethrin, we give crotamycin. So it is also a type of antiparasitic, but it doesn't cause any problems in the infants. More than 2 months of age, permethrin to the whole body except face and neck. Second line treatment, older than 6 months, you can give benzyl benzoate. Third line agent is 5 years or older, you can give ivermectin. So first line in less than 2 is crotamycin. More than 2 is permethrin. Second line in more than 6 months, benzyl benzoate. And more than 5 years, you can give ivermectin. Clear, guys? Any question? I've given you the RSCGP link as well, so you can study both from here. Okay, next question. Less than 2 months, crotamycin. More than 2 months, permethrin. But if they haven't given you options of crotamycin, just give permethrin to everyone. Okay. Lady with mental developmental problems shows unwanted romantic action to support worker. Says that she wants to suicide because of love, then changed her mind, believes that support worker is secretly in love with her. Which features are significant for diagnosis? So they have just given us 2 options. Either it is a delusion, associated erotomania, or suicidal ideation. Very clear, or always remember, suicidal ideation will be present in either bipolar disorder or psychotic patient, or in patients who are having major depressive disorder. They will not have any delusion. They will have a clear plan to end their life. Okay, clear plan to end their life is suicide ideation. This here is erotomania, which is a delusion in which a person imagines themselves in love with another person, but that is not the reality. I'll just explain the definition to you. I won't go into much detail about this. Erotomania is uncommon form of delusion disorder. Delusion disorder is a disorder in which you have a unwavering belief that something is real. in which an individual has unfound belief that another is in love with them. Social media networks may play worse role in worsening the delusion disbeliefs. So social media doesn't help. There's a case report in NCBI journals regarding that. I've just taken a definition from here. Clear, guys? Next question is the surgical question. A patient is coming with right up quadrant pain, fever, high LFTs, jaundice, with stones in the bile duct on ultrasonography. Which of the following is the next best management? Okay, so we have, what is the situation the patient is having? Can anyone tell me what is the name of the disease patient is having? What is this? Obstructive jaundice, very good. Fever with obstructive jaundice is? Fever with obstructive jaundice is called? Polydeucholithiasis, yes. Obstructive jaundice is there, but fever on top of that, very good. It's acute cholangitis. Fever, so always remember three things. Febrile patient, jaundice, right upper quadrant pain is acute cholangitis unless proven otherwise. You have done ultrasound, it shows stone in the bile duct. Proven. Best thing is you resuscitate the patient and then you do ERCP. ERCP will remove the stones and will do sphincterectomy as well. Okay. So this is acute cholangitis with that you need to do ERCP for. This patient will need laparoscopic cholecystectomy in the future to prevent acute cholangitis happening again. Okay. Percutaneous retrograde decompression is done when we can't approach the patient through laparoscopic cholecystectomy or ERCP. They're not eligible for that. Then we do percutaneous retrograde decompression. Okay. Why not A here? What is the laparoscopic cholecystectomy going to do in acute cholangitis? It's not acute cholecystitis, it's acute cholangitis. Like the biliary tree is having the infection because there is obstruction there of the bile duct flow. So we need to do ERCP. Acute cholangitis, it's a surgical emergency. You need to resuscitate the patient. So airway, breathing, circulation, hydrate the patient, antibiotic needs to be given. Correct metabolic abnormalities as well. If it's mild, then you need to closely monitor and you can do elective ERCP instead of emergency ERCP, right? If severe or unstable, then urgent ERCP with biliary decompression or definitive management. If no clinical improvement or failure of ERCP, then you can do percutaneous drainage. If clinical improvement, then elective ERCP with definitive therapy, if not previously done in the ICU setting. Okay. Can anyone tell me what antibiotics we use for cholangitis? Can anybody tell me what antibiotics we use for imipenem? Big antibiotic. Metronidazole, very good. And no, we don't give gentamicin. So what's the causative agents for acute cholangitis? Who said E. coli? Dr. Devi, very good. You're absolutely right. You get a pop-up. So E. coli, Klebsiella, Enterobacter, and Enterococcus. These are most common organism. Why can't ERCP be done in gastric bypass? Because you don't have access. All right. So E. coli, Klebsiella, Enterococcus, and Enterobacter. So these are all the organisms that are usually causing the infection. So you can treat them with penicillins and metronidazole. So you need to cover gram positives and anaerobes, right? You can cover them with either penicillins or cephalosporins with metronidazole. So you can give ampicillin, you can give ceftazidime, you can give piperacillin, tazobactam. Not working, then you go to meropenem and imipenem, not before that. Metronidazole is a common denominator here. Okay. Another surgical question. You have a Barrett esophagus diagnosed, and Barrett esophagus is now coming with high-grade dysplasia. Which of the following is the next step in management? Do 3-month surveillance, do surgery, or endoscopic ablation? It's a high-grade dysplasia, guys, not low-grade dysplasia. What is going on? So, okay, let's look at this first. Barrett esophagus needs to have lots of surveillance, right? Because it's prone to develop into adenocarcinoma of the esophagus. And the risk factors for developing Barrett esophagus is reflux. So you have seen that patient is having columnar lined esophagus instead of the other cells. You do a biopsy and it shows Barrett esophagus with no dysplasia. So you repeat the endoscopy, Cancer Council Australia. So you do endoscopy surveillance 3 to 5 years. If the length is less than 3 centimeter, if it is more than 3 centimeter, you can do 2 to 3 years. If it is showing dysplasia on biopsy, then you can repeat the endoscopy in 6 months. Maximum ACE suppression. And if the repeated endoscopy shows that patient is having dysplasia inside, then you follow another protocol. If it is indefinite dysplasia, then again you repeat in 6 months if there is no change in the centimeter. Or if it develops into low grade or high grade, then you follow that protocol. Low grade dysplasia on biopsies, you repeat the endoscopy. If 2 consecutive 6 months endoscopy shows that there is no dysplasia, then you consider less frequent follow-up. But if it shows indefinite dysplasia, then you refer the patient to the gastroenterologist. High-grade dysplasia always require patient to be referred for either endoscopic ablation or surgery. Okay? So nowadays, instead of doing surgeries, they do endoscopic ablation. So this person will be a good candidate for endoscopic ablation. Okay, guys. This is the general, Australian general as well, that can tell you about new practices for Barrett esophagus. But no dysplasia, then you can extend the surveillance. For example, if less than 1 centimeter metaplasia identified, no follow-up required. 1 to less than 3 centimeter, 3 to 5 years. More than 3 centimeter, 2 to 3 years. Indefinite dysplasia, the need to repeat endoscopy 6 monthly with biopsy. Low-grade dysplasia, repeat 6 monthly endoscopy. If any of the endoscopy shows change, then you need to refer the patient and treat it as high-grade dysplasia, either with endoscopic ablation. If not tolerating endoscopic ablation, this patient needs to go to the for esophagectomy. All right, next question. Oh, everyone knows this. Can anyone tell me the ECG of the pericarditis? What are the common findings? More common than ST elevation in all of the leads. What is more common and early sign of ST pericarditis? No, no tall T waves, not ST segment elevation. What is it? No. PR depression. Who said that? Very good. So initial part of the pericarditis is that you will have PR depression and ST segment elevation. Even if you can't see ST segment elevation diffuse throughout the leads, if you see the PR depression throughout the leads, then these are the initial signs of pericarditis. What are the clinical signs and symptoms of pericarditis? Sharp stabbing pain, pleuritic chest pain, more when patient is lying back, relief when leaning forward. Yes, very good. And we treat the patient with what? NSAIDs, indomethacin. All right. If the patient is not responding to NSAID, what else can we give patient for treatment of the pericarditis? What is the second line drug? Is this very good, Dr. Acer, George, Mohammed? It's colchicine. We give colchicine. Initially, we treat with NSAIDs, but you can't use NSAIDs for a long period of time because of the side effect of causing gastritis and gastric ulcers. So we treat the patient on the maintenance therapy with colchicine for 3 months. Alrighty, very good. I don't think so. We need to discuss about that. You guys have told me everything. Does this patient need to have echocardiography or not? Every pericarditis patient, whether should have a echography or not? Okay, not really. Why? One of the very common side effects of pericarditis, if left untreated for a long period of time, is pericardial effusion, which is life-threatening if it gets very big. So every patient with pericarditis gets an echo. They need to do an echo to see whether the patient is having pericardial effusion or left ventricular dysfunction as well. Okay. Patient who can't be given NSAIDs in acute flare-up can be treated with steroids as well to decrease the inflammation. Alrighty. Next question. My favorite ECG. Not very favorite. You can preemptively give them aspirin if you're thinking of a STEMI, but aspirin has no role in pericarditis. It will not help with the pain. Okay, 65-year-old man is coming in emergency department with chest pressure associated with nausea and diaphoresis. ECG is following. What to do first? So now you can give him aspirin. Why? Why are we giving aspirin to this patient? What sort of ECG findings are you seeing? It's a STEMI, but what STEMI? Talk to me like a doctor. Don't talk to me like a medical student. What are the ECG findings? Very good. Anterior lateral. Very good. Excellent. So this patient is having anterior lateral infarction with the right bundle branch block. Very good, Dr. Shabi, Dr. Tina, Dr. Devi. So this is anterior lateral infarction with the anterior chest leads and the lateral leads showing ST segment elevation. And there is a right bundle branch block as well. So this patient is having STEMI. So what is the initial management? We give aspirin. Other than aspirin, what else you need to give to the patient? Can anyone tell me? We need to give clopidogrel. Very good. GTN you can give to the patient to help with the pain. Inferior or right ventricular infarct, don't give GTN because it will cause reflux, hypotension, and bradycardia in the patient. Oxygen, if you think that the saturation of oxygen is low, then you can give oxygen. Otherwise, it's not necessarily that you give oxygen to the patient. But initially you give 300 milligrams of aspirin. If the patient is in the tertiary center with the access to percutaneous coronary intervention, then we start the patient on heparin infusion, send them there. If the patient is not there, then always give them clopidogrel as well. Very good. Okay, next question, guys. Patient post-delivery comes with lower abdominal tenderness and bleeding on 5th day. Has been given cefalexin. What do you want to add in the management? Flucloxacillin, gentamicin, or metronidazole? Very good. So what are we trying to cover the patient for? Can anyone tell me? Bleeding, lower abdominal tenderness. Always cover the patient for gram-negative. No, metronidazole cover for anaerobes. So we are trying to treat either patient is having a placental retention or patient is having endometritis, not endometriosis. Endometritis. So we will give the patient metronidazole with cefalexin. SA Health. My favorite guidelines to use whenever I'm dealing with the obstetric-gynae patient. I always review these. These are very helpful. So, okay, they talk about the antibiotics you can give. So peripartum period, if patient is group B streptococcus positive, then you need to give patient pen before labor or during labor. If the patient can't be given penicillin, you can give cefazolin as well, because we need to cover streptococcus, which is a positive agent. So you can give, and it's present in the skin. So GBS can be covered with benpen, or you can give cefazolin. If you can't give cefazolin, always give clindamycin. Okay. So always remember benpen, cefazolin, clinda, BCC. Instrumental vaginal delivery, most of the time we don't give anything, but it's recommended if you have manipulated a lot, then you give patient augmentin, because we need to cover for all of the urinary tract and skin problems as well. Augmentin, cefazolin with metronidazole, or you can give patient clindamycin or gentamicin, because we are covering gram positive, gram negative, and anaerobes here. So augmentin is it's like a sniper. Benpen, cefazolin, clindamycin. So augmentin is a sniper. Augmentin is very specific, covers everything. But if you can't give augmentin because of the penicillin allergy, you can give cefazolin, but you need to cover the anaerobes as well. So you give metronidazole. And if you can't give that, you need to give clindamycin. Again, you need to cover anaerobes and you can give gentamicin with it. Same thing for manual removal of the placenta. Always remember that. Perineal tears, cefazolin sometimes, clindamycin, but it's not recommended. Oral augmentin is recommended. Endometritis. Where are you? Premature rupture of membrane for chorioamnionitis. You just give amoxicillin or oral erythromycin because we need to cover for gram positives and atypical ones as well. So amoxi and azithro. Always remember pre-prom with no or yes signs. Always give AA, which is azithro and amoxi. What is this? Chorioamnionitis is the same. Amoxi, gentametro. Where is endometritis? Endometritis, amoxi, gentametro, cefa, gentametro, clinda, genta. Okay, so endometritis and chorioamnionitis have same treatment. Yes, please. I would recommend you guys to read these articles. It will help you in an exam. Okay, another question from Gynae and Ops. Pregnant lady? It is too much, but it will help you pass the exam. Because they do ask particular antibiotics. Pregnant lady with severe headache, especially on the vertex since 1 month. She is in her 3rd trimester and has a constant blood pressure of 160 by 140. Very, very high. Which of the following is the initial investigation? Serum electrolytes and serum creatinine, CT head, or urine dipstick? What are we trying to rule out here, guys? Very good, you're very good. Preeclampsia. So initial test for preeclampsia is urine dipstick, and we look for what in urine dipstick? Proteinuria. Very good. Very good class. I'm not going to go in much detail about preeclampsia here, but I'll let you know what we look for. Okay, so I'll just quickly go towards investigation. Sorry, I'm just going very quickly looking for preeclampsia. Where are you? Oh, can't find it. There you go. Okay, initial investigation for new onset of hypertension after 20 weeks of gestation. In a spot urine sample, which is urine dipstick, full blood count, creatinine, electrolytes, urate, liver function tests, coagulation studies, with the ultrasonography to look for fetal growth, amniotic fluid, and umbilical artery Doppler assessment. These are the investigations we do. Clear, guys? All right, again, very easy question. And it's medical and surgical emergency. So sign indicating that intestinal ischemia is which of the following? Colicky abdominal pain, atrial fibrillation, loose motion, vomiting, or PR bleeding. Very good. So atrial fibrillation is associated with every kind of thromboembolism phenomena. It can throw the thromboembolism to your heart, to your brain, to your legs, and to your gut as well. So you can get stroke, heart attack, intestinal ischemia, and peripheral acute limb ischemia as well. Acute mesenteric ischemia. Risk factors to consider is age more than 60, atrial fibrillation, recent myocardial infarction, valvular heart disease. Already you have a aneurysm or atherosclerosis in your aorta, instrumentation of the aortoiliac artery or surgery. So patient stable, unstable, imaging is CT angiogram we usually do. If diagnosis is still in question, that this requires laparotomy or arteriography. Management is you inform the surgeons, you do arrange for or organize laparotomy, start the patient on ampicillin, gentamicin with metronidazole, heparin if there is no contraindication, and rush the patient to theater to do laparotomy and remove the clot and the ischemic gut from that area. Clear, guys? Alrighty. Okay, next question. 44-year-old female with worsening left foot pain, sharp burning, worse on walking. Between her third and fourth toes, with tenderness on third and fourth metatarsal. What is the diagnosis? Motor neuroma, tarsal tunnel syndrome, or bursitis? Very good. So motor neuroma is very common. It's the inflammation of the nerve in between third and fourth, second and third toes, and it can cause pain, especially tingling, numbness, burning pain on walking. It requires pain relief, resting, icing, compression, and elevation to help with that, and a lot of physiotherapy as well. You can have a look on motor neuroma here on the ortho, or you can study from the JM as well. All of these topics are there. Motor neuroma, it's not a tumor, but it's a thickening of the tissue or inflammation of the nerve itself. So big toe, second web space, third and fourth web space. These are all the nerves and the tissue surrounding it. When the tissue gets inflamed or the nerve gets inflamed, it causes pain in the distribution of that nerve as well. This is how it looks like. Okay. Symptoms: persisting sharp pain, sensation of having a pebble or a marble in between their toes or under their forefoot, areas of nerve supply causing the pain there, splinters as well, shoe wears problem can be there. So you evaluate, you don't need to do anything else. It's a clinical examination, and you press in between the foot spaces, that will produce pain. So you change the type of shoe, you can give steroid injections, or you can give extracorporeal shockwave therapy as well. Radiofrequency ablation, not very commonly used, but you can do surgical treatment. You remove the portion of the inflamed tissue from around the nerve, or you remove the disease portion of the nerve itself as well. Dr. Gian, can you please stop the writing on the screen, please? I'm unable to remove this. Can you please remove that from your screen? Thank you. All right. Another question, interestingly from gynecology. 25-year-old comes to GP clinic and complains of primary amenorrhea, which means she never had periods. On physical examination, she has a webbed neck, wide-spaced nipples, and her breast is at Tanner stage 1. She's also short-statured. What is the best investigation of choice here? Karyotyping, hormone profile, pelvic ultrasound, thyroid hormone, or bone aging. So we just have reviewed this. This is karyotyping. Very good. It's the same guideline we previously reviewed, the flow chart. So for periods, primary amenorrhea, bone age, it's the same thing that we start with. So secondary sexual characteristics present or not. If they are not present, initially we do FSH and LH levels. If the FSH and LH levels are low, we think about whether the gonadotrophic hormones are not being produced and they are causing hypogonadotrophic hypogonadism. If the FSH and LH levels are high, then this is hypergonadotrophic hypogonadism, and we do karyotyping. So it can be either Turner syndrome or premature ovarian failure. If secondary sexual characteristics are present, then we don't do hormone levels because we know there is nothing wrong with that, but we do an ultrasound to see whether there are structural abnormalities. So if the uterus is absent or abnormal, then we do karyotyping. But if the uterus is present and it's normal looking, then we look at the outflow tract, whether this has obstruction or not, and whether there is an imperforate hymen or transvaginal septum there or not. So this is how you examine a patient for primary amenorrhea. Similar here, same thing. Any question, guys? Okay. Next question, 68-year-old patient is coming to you with back fracture. Painkiller NSAID you have given. Pain is not settled. How will you manage his pain next? Give oxycodone on top of NSAIDs, give him morphine, give him gabapentin, give him ketamine, or give him a nerve block. Oh, you're giving ketamine. Dr. Mariam, that's a lot. That's a big jump. So there is what is followed is a pain pyramid, okay? You can't jump on different options without going through the pain pyramid. If a patient has been given non-opioid analgesia like NSAID, the next option we go for is the weak opioids, which is endone, oxycodone. Step 3 is if the patient is not responding to weak opioids, we go to strong opioids like methadone, oral administration, or transdermal patch. If the patient is not responding to step 3, then we can give nerve blocks, epidural, percutaneous analgesic pump, neurolytic blocks, or spinal stimulators. Okay, so here weak opioid is oxycodone. Morphine is a long-acting one. Gabapentin is it's given for the nerve pain. For example, patient is coming with the peripheral neuropathy, we give gabapentin. Ketamine is a kind of a NSAID, but it's given for patients who are having muscle spasms pain. For example, if they have back fracture and then they freeze their back muscle, they are unable to mobilize, then we give them ketamine to relax. Nerve block is the step 4 of it. If patient is having recalcitrant pain not controlled by all of this, patient is palliated, then we consider nerve block. Okay. A child of 6 years presented with 1-day history of acute earache and high-grade fever in the emergency. You are an intern on duty. What do you want to do? IV antibiotics, analgesics, antipyretics, oral antibiotics, or you want to admit the patient in the hospital or observe the patient. So very young child coming with earache, high-grade fever, and you're an intern. What do you want to do? Very good. So every acute otitis media, unless there are no red flags, we just give paracetamol and ibuprofen for the first 48 hours. If the patient is not responding, then we start the patient on amoxicillin. So what are the red flags? If the child is less than 6 months old, immunocompromised, Aboriginal or Torres Strait Islander, had recurrent infections or cochlear implant and 1 ear, then you start the patient initially on antibiotics. But if it's normal child with no risk factors, then 48 hours of at least ibuprofen and paracetamol. If not improving, then you need to give amoxicillin or augmentin as well. Always advise the parents that after completing the course of the antibiotics, they should have a hearing test in the child with audiometry and otoscopic examination. Okay. Thank you, guys. This was all for today. I hope you had a wonderful session. I quite enjoyed actually with you guys. It was wonderful to meet all of you, to discuss the questions with all of you, to try to clear how the exam works and how I can help you guys in this course to get a good grasp on your basics and how to solve the questions as well. So if any of you are going to be opting for our course in the future, I welcome you all. If you're not, then I wish you best of luck. Try to study really hard, but make everything like your concepts really clear about it. So my advice is always study things side by side. Theory with the sample questions, try to do them side by side. You will have 2 to 3 recall classes in a week and 1 theoretical class, depending upon which system you're going through. Sometimes now Dr. Arshan will take 2 classes per week as well, but there will be 3 recall classes and 1 theoretical class. So tips of study is that make yourself a schedule that you are not going to study more than this many months. Try to divide your time, go through the theoretical part quickly, make sure that you are going through the guidelines as well to keep yourself updated, and then practice as many sample questions as you can. Yes, there is a schedule released every fortnight. Thank you so much, everyone. I wish you all how to finish 150 questions on time. You need to be efficient. Practice will do that. Recall classes is 4 times per week. So you will still have all of the recall sessions if you're just joining the recall classes. Yes, all of these will be discussed if you're joining the theoretical classes or the course itself. Yes, schedule will be given to you on the Facebook. You have already studied everything in detail in your medical life. So try to go through JM as quickly as possible. Don't read every word. That's why Dr. Arshan, he goes through selective part of it so that you know the concept. You just need a brush of it and what is done systematically and strategically here in Australia. No worries. So good night, everyone. Best wishes for your exam and preparation. I hope to see you, most of you, in our course. If not, then best of luck for your future and for your exam. Thank you so much.